but you guys all should have this slide, okay? So we're gonna start over here. So this is the beginning of lecture 6. And I wanna get into detail about the osteology of the foot. And if anyone wasn't here about me talking about why, it's because a lot of the structure is in the lower leg attached to the foot. And so it's important to know kind of the osteology, so you know where they attach, why they attach there, and clinical implications about where they attach as well, right? So what I'll do is I'll start from the top. We're going to start with the phalanges, and they have the exact same name as we do with our fingers. We call our fingers phalanges too. The great toe is to the left of the diagram, and I think that's pretty obvious based on the size over here. And then we have the metatarsals, which is what we call the midfoot as well. And then we got the tarsals over here, which is like analogous to the carpal bones we had in our wrists, okay? So let's just start over here on the right. And what we have is a lateral view of our right foot. And the reason why I know it's lateral is because I can see the styloid process here of the 5th digit. I'm going to explain that later. I'm just explaining why I know this is the lateral side. But I just want you to take a note of this red curved arrow. And that's the natural arc of our foot. And the foot, even on its bony, through all its bony joints and attachments, creates this arch naturally. And everyone has some form of an arch. Some may have a flat foot, but you'll still have an arch. Everyone differs, right? And one thing I wanted to get out of this discussion about the arches is that people usually equate a flat foot with a bad foot. But what I always tell my clients is that, especially when they see me and they say, oh, I have flat feet, it's almost like a diagnosis of a terrible syndrome to have flat feet. Flat feet is actually not a super bad thing, right? A highly supinated foot or a highly curved foot can also present with its own problems as well. And just generally speaking, a curved foot, a more supinated foot, or one with a really high arch, tends to present more problems with like stress fractures and rigidity in the foot, whereas a flat foot is a little bit less rigid and presents more problems with tendonitis and plantar fasciitis. But both of them have their inherent problems. So one thing I want you to take from that is that it's never usually a one is a problem, one is not. There's usually two different extremes to things, right? And it's a continuum. So a highly curved foot and a highly flat foot both present with its own problems. And even having in between, you might have some problems with that as well. So and this is just to actually point out as well that anatomy is a lot more complicated than just labeling things very generally like that as well. So flat foot doesn't always mean a bad thing. Curved foot doesn't always mean a good thing. Okay, so let's start with the top over here. So the phalanges. You'll notice that similarly to the hand, the foot also has 14 phalanges, and that's because the great toe only has a 2, while the remaining 4 digits has the 3, right? So the great toe will have the distal phalange and the proximal phalange, and digits 2 to digits 4 will have the distal, the middle, and the proximal phalange. So those are the biggest differences there. Again, the toe is a lot bigger because a lot more stress goes off in the toe when we walk. And it's the last thing that kind of propels us forward when we take a step. So the last part of the gait cycle or the walking cycle is when we have what we call toe off, which is the last piece of contact of our foot is actually over here. So because of that, the toe must be stronger, more solid, and have more muscular attachment to help us propel forward. And you kind of see that in its osteology as well, being a lot bigger than the remaining fingers, or sorry, the remaining toes over here. Now, when we get into the metatarsals, you can also equate them with the metacarpals that we had in the hand. These are the part of the foot that you don't see as separate kind of pieces. They're all just in that midfoot, but you can feel them, you can palpate them. Some people have a lot easier time palpating than others. It really just depends on the thickness of the subcutaneous tissue that's underneath the skin. Their primary role is to connect the phalanges to the tarsals, so they're the kind of the intermediary between the two. They join with each other through interosseous attachments, and then they attach proximally to the tarsals with joints known as the tarsal-metatarsal joints. So tarsal, metatarsal joints. So these are the joints over here. If you can just take a quick look at my cursor. So that's an attachment point between the metatarsal and the tarsal bones. The joint, I guess I didn't write that down in the slide. So tarso-metatarsal joint, or TMT for short. And then the joint that connects the metatarsals to the phalanges is called the metatarsal phalangeal joints. So let me write that down. That's MTP for short. Okay. So then if we go a little bit more proximally, we get into the tarsal region. And again, these are analogous to those 8 carpal bones we have in our hands, which is pretty cool. I mean, there's a lot of similarities between the hands and the foot. The biggest difference, of course, is that all the weight of the human body has to go through the foot, but otherwise it's pretty similar to the two. The superior most structure of the foot is called the talus, and you can actually see why it's a superior most when you look at the lateral aspect of it. The talus is also the place that transmits the entire weight of the human body onto the foot. So it's because the talus is what connects the lower leg with the foot through the mortise. We talked about the distal tibia and fibula in the last lecture, which is a continuation of that lower leg. This is where it would attach, and you can actually see that articular cartilage over here as well when you look at it superiorly. Okay. The talus has 3 separate articulations or connections to the foot or leg. So superiorly, so on top of the talus, it connects to that tibia and fibula, the shin bones. Inferiorly, or below it, it attaches to what we call the calcaneus, which is the heel bone, and you can see that joint over here. And then anteriorly, or in front of it, it attaches to the navicular bone, which you can see in both diagrams as well. So numerous attachments, and the talus probably has the most ligaments in the foot. And many of you may have even injured them at some point. So the most common way to injure your ankle is to do they would call it rolling your ankle, but it would be a plantar flexion inversion injury. So we'll kind of talk about those movements in a bit as well. But in any case, the most common way to roll your ankle will also be damaging those ligaments that help support the talus to the fibula as well as the rest of the foot. So the talus has a lot of different ligaments. I'm not sure if any of you have heard of the ligaments. There's the ATFL, the CFL. No worries, Tara. So the question is superior plus anterior plus what connection for the talus? So let's go over the connections real quick. So the talus is over here. If you take a look at where my cursor is on the shared image. And anterior to it, so in front of it, we have its connection to the navicular, which is another tarsal bone. So that's the connection over here. We call it the talonavicular joint. Okay. Now, inferior to the talus, which is over here, you can see in the lateral view, so right below it, is the joint between the talus and the calcaneus, which is the talocalcaneal joint. Okay, and then superior, so above the talus, would be its connection to the shin bones, so the tibia and the fibula. So we see the lateral aspect of the talus right now, right over here, because this is the lateral foot. So my question to you guys now is just to get an orientation is, which bone would you see on this side? Would you see the fibula or the tibia? The distal fibula or the distal tibia? Which one do you guys think you'll see right now? Give you guys a chance to answer that. And it'll kind of give me an idea of whether I'm teaching the orientation properly right now or not too. So let's see what you guys think. Okay, so we got one answer. I'm waiting for a couple more. And guesses are fine too, guys. Don't worry if you're not sure. I'm more worried that, you know, I want you kind of to attempt an answer, and even if it's wrong, it's 50-50, but also like if you are wrong and then you get the right answer, it will kind of like, the best way I usually learn is by making mistakes when I, you know, try to get something. And it's because in my mind, it's like, it causes such an irritation that I'll never forget the experience of the irritation of not getting an answer right. So for me, that kind of works well. Okay, so we have a few answers. Good, good. So everyone's answering it correctly, which is awesome. It is the fibula. Another name for the fibula at this part of the leg is called the lateral malleolus. And we talked about that in an earlier lecture as well. That's that. If you look at your guys' ankles right now, the outside of it, that very bony part that sticks out laterally or out to the side is your lateral malleolus. So that's where that fibula, the distal fibula, would be sitting. The lateral malleolus is just that bony prominence that sticks out of the fibula at the bottom over here. Okay, guys? All right. So let's carry on. So beneath the talus, we got the calcaneus. So you can see that it's a pretty big bone, and it actually, in fact, is the biggest bone of the foot. Another name for it is the heel bone, at least a street name for it is. And you can imagine that a lot of the weight of the foot goes through here to make contact with the floor. So that is why that the calcaneus adapted as being such a big bone, is because a lot of force has to go through it. So it needed more density, more surface area, and then you can kind of see over here it has a round edge to it, and that's to allow us to kind of propel ourselves forward a little more effectively, like a swinging motion. Of course, underneath it, you don't see it, but we have what is known as a heel fat pad, and that's kind of the cushion we have between the skin of our heel and the calcaneus, so it's not just skin to bone. There's also that heel fat pad. I don't know if we'll be talking about it later in the lecture, which is why I mention it right now. And then we have what we call the Calcanealtubercle, which is this bony prominence over here. And I'll write that down because I'm pretty sure I did not label it anywhere. Calcanealtubercle. Now, my question for you guys right now is, what do you think attaches to that Calcanealtubercle? Which very strong structure attaches here? If you guys remember from the previous lecture, we were talking about it. Awesome. And right away, we're already getting the right answers. That's awesome. Okay. So let's just wait for a couple more. Okay, so I guess I asked a better question this time. All right, cool. So yeah, you guys are all absolutely right. That's the Achilles tendon. It's the strongest tendon of the human body. It also originates, well, it's an extension of our gastrocnemius. So our gastrocnemius, the two heads of the gastrocnemius, the medial head and the lateral head, as well as the soleus. And those are those really strong plantar flexors of the ankle. Those are the ones that really get worked when we, you know, do a heel raise or quote unquote work our calves. So you got it. That's where the Achilles tendon would attach, right over here. Awesome. Okay, so the next tarsal bone I want to talk about is the navicular. I think in Latin it translates into a boat, and I think it translates into a boat because they imagine it looked like a boat. But in any case, The navicular is anterior to the talus over here, and it's considered pretty much the middle of the tarsals. I mean, you got the hind portion, the middle portion, and then you got the front portion. So it's pretty much the middle. And because it's in the middle, it articulates with the most different bones of the tarsals, meaning it has joints with most of the bones. It has 5 different articulations actually. So anteriorly, so in front of the navicular, it has attachments to the 3 cuneiform bones over here. Laterally, it has an attachment to the cuboid. And then posteriorly, it has the attachment again to the talus. So lots of bony attachments. It's a bone that I like to look at a lot in people with a dysfunction in their foot. It's probably my favorite bone in the foot, just because of how many attachments and how many different ways you can find to kind of damage it. But yeah, it's that one, you can call it the middle of the foot almost, right? And then on its plantar surface, so on the bottom, it contains a tuberosity that we're going to talk about later. So remember, tuberosity is that bony prominence that comes out of the bone. And on that tuberosity is a muscle that we're going to talk about that kind of attaches to it. Okay. And then if you look laterally on the foot, we're looking at the cuboid. So just lateral to the navicular, we got the cuboid. And that is anterior to the calcaneus. So the cuboid over here is the same bone over here. Okay. Now the inferior surface is actually, if you look over here, there's a bit of a groove. And that groove is there for a reason. We're going to talk about it in a bit as well. But that's a special place for a tendon to run through. So the bone kind of accommodates this pathway for the tendon to run through, which I think is pretty cool. And then what you'll notice is that, so we're looking at the top view of the right foot. What you'll notice is that at the very edge of the foot for the 5th digit, we have this protrusion over here. And we call this the styloid process, because you see how there's a little bit of a bony bump that exits posteriorly. The styloid process is an area where another tendon of the leg attaches, and we're going to talk about that in a bit. But just keep in mind that it exists. And if you feel the side of your foot right now, so I don't know if you guys have shoes or socks on, but what you can do is actually go where your heel is laterally, and then just go anteriorly from where your heel is laterally until you feel a bony bump. Everyone has one. That bony bump you feel on the outside of your foot right now is the styloid process of the 5th digit, right over here. Okay. The reason I pointed out is because it's often implicated in injury, specifically what we call an avulsion fracture of a bone. So there's many different ways you can fracture a bone. One of the ways you can fracture a bone is actually through an avulsion tear, where the tendon pulls so hard on a bone that it will actually rip off just like a surface piece of it, versus like an oblique fracture, which is like a line fracture of the bone, or a compression fracture. Those are different kinds of fractures, but this area is a very common site for an avulsion fracture. And my guys who roll their ankles tend to have injuries over here a lot as well. I think that's all I had to say about the foot. Did anyone have any questions? I mean, I know this is a very heavy slide. Any questions so far about the foot and what we talked about so far? I know sometimes, in fact, quite often I talk really fast. In my mind, I think I'm talking slow, but I think I'm talking faster than I think. Okay, cool. All right, so the following 2 slides are not in your lecture slides, and they turned out really bad in quality. My goodness. Reminder to self, don't use the snipping tool to take an image. That's horrible. Anyways, this is kind of a way to give you an idea how the medial foot, so the inside of your foot looks, versus the lateral or the outside of your foot looks. let's start with the medial though. So this is the inside of your foot, okay? And again, we see a lot of the bones that we were talking about before, but it's helpful to kind of see it at a different angle. So we have the phalanges over here. You'll know that you're looking at the inside of the foot for a couple of reasons, but what do you guys think I'm using as the biggest piece of evidence to know that I'm looking at the inside of the foot versus the outside of the foot? I want to pick your brains for a second here. So what's a good piece of evidence that we're looking at the inside of the foot versus the outside of the foot right now, without me telling you that we're looking at the inside of the medial foot? Okay, so the calcaneus is a good one. The calcaneus is a little bit more hollow on the inside of the foot. I'm looking for a more obvious one. There we go. Awesome. You're absolutely right. So the big toe, as you can see over here, only has 2 phalanges. And we know that the big toe is the medial most toe of the foot. So that's the biggest piece of evidence right there. And then I guess if you understand the shapes of the bones, we talked about that styloid process that you don't see on digit number 1, but you definitely see in digit number 2 over here. And then let's see if there are any other pieces of evidence. I mean, you can see the navicular medially, whereas if you look laterally, you're going to see the cuboid, which has a different shape. It's more of like a cube shape, whereas the navicular is more of that rectangular shape. So now I'm just getting really detailed, but just to give you an idea of what we think about as anatomists sometimes. Yeah, it just helps us orient and understand the relationship between the different bones and stuff. Okay, so over here you can also see the joints in a little more detail as well. So that tarsal metatarsal joint, which connects the tarsal bones to the metatarsal, and you got the metatarsal phalangeal joint over here, and then you got the interphalangeal joints over here. And again, you can see how big that calcaneus is, and we need it to be big because it's accepting a lot of the force of our human body, and this is what transmits most of our body weight into the floor, right? So it has to be big. And then you see the articular surface again of that talus. So when we look at the lateral view, you'll notice that the calcaneus is a little bit closer to us. It's not as hollow over here. Again, you'll see the cuboid on the lateral side, the styloid process of the 5th metatarsal you're going to see as well. If you count the phalanges on the lateral aspect, you know that you're looking at the pinky toe and not the great toe because we have 3 phalanges, but also because it's a smaller phalange in size in general. Not much else to really note with this slide though. Okay. So what we'll do, guys, now is we're going to go back to lecture 5, and we're going to be going to slide number 9. Okay, and we'll give everyone a small little break just to get to these slides, and we'll get started in about a minute or 2. Okay, so if anyone's not ready for this lecture, just let me know. We're on lecture 5, which is a lecture that I did not finish last time. We stopped at the slide before this one, which was the posterior leg, the superficial group. So if you remember, we're talking about the gastrocnemius, the medial and the lateral heads of it. And then we removed that out of the way and we talked about that big soleus muscle and that smaller plantaris muscle. We talked about the proprioceptors of the human body. I think I may have asked you guys to Google search it for more details about it and how the proprioceptors allow us to understand where our body is in space without using our visual system. There's that Achilles tendon, that very powerful Achilles tendon, and it has to be because it's what propels our body forward. So we need that integrity there. But again, because it has to go through so much force, it's often injured as well. We talked about the triceps surae being the combination of the medial and lateral gastrocs, as well as soleus. The reason why we call it triceps surae is because all these muscles eventually turn into that Achilles tendon. Okay, so now we're into the deeper group. So what we did was we removed the gastrocs and the soleus out of the way, and we're looking at the deeper muscles. And the first thing you'll notice is that they're not as big. And that's because they're a little more intricate. They're more involved in controlling the toes per se, as well as the ankle. But again, they're still very important. Now, my question to you is, we know we're looking at the posterior leg, right? So it's back leg. What is the biggest clue you think? Because, I mean, it is a kind of hard to tell, right? What would be the biggest clue right now that we're looking at the posterior leg and not the anterior front of the leg? What do you guys think? So why are we looking at the posterior leg right now? Without giving me the answer that everything says posterior. Good, good, good. I like the answer. No patella. So no patella is good, but let's say I move the patella out of the way. Let's say I'm like, okay, fine, no patella, but what if I just got the patella out of the way? What if I didn't want to see the patella? What else would give me? Yes. Yes, yes, yes. You guys are awesome. So I wasn't even thinking of the patella, but that's actually a good answer. The notches, the femoral notches, aka I think what I was more looking for is the condyles. So the condyles of the femur, right? These are way more prominent posteriorly. And the reason why they're more prominent posteriorly is that our knee bends backwards. It doesn't bend forward. So we need way more articular cartilage behind the femur, right? Because that's where the shin's going to roll. It doesn't roll forward. So when you look forward, you're not going to have these condyles available, because unless you want to hyperextend your knee, which I never recommend you do, you don't need condyles in front of your femur. You only need them behind your femur, where the shin is actually going to articulate with when you bend your knee. So that's, to me, that's the biggest piece of evidence that we're looking at the posterior leg, right, as opposed to the anterior leg. But in any case, good job, guys. You got the right answers. I love it. Okay, so let's start with, I don't know, which one should we start with? Let's start with the popliteus, because it's the most superior muscle of the four that we're going to talk about. So although I didn't really give it a nice blue color to it, the popliteus is very important as well. If you can see, it originates from the lateral condyle of the femur, but it kind of takes this oblique turn to attach to almost the medial posterior surface of your tibia. And there's a really important reason why the muscle crosses over. Now, you'd think that just by association, when it contracts, it might be a knee flexor or knee bender, but its primary role is not actually to flex the knee. In fact, I don't even know how effective it is at bending the knee, just because of how it's angled. But it's a very important muscle for the knee, and it's because it actually unlocks the knee. So hear me out for a second. So when you're standing, everyone, for the most part, is a knee extension, right? The knee is fully extended. The reason why we're in knee extension when we stand is because it minimizes how much muscular, activation we need to be in that position, right? It's a very passive process to stand with your knee straight. Now, I'll give you the opposite scenario where, let's say you stand with your knees a little bent. Now you're activating the quads and the hamstring muscles a lot, right? So I don't know if you guys ever remember doing the electrical chairs in the gym class. At least I called it the electrical chair because it was such torture, where you're against the wall with your back against the wall and your knees are almost bent at 90 and you're holding that position for as much as you can, right? If anyone knows any other name for that exercise, let me know now, but I've always called them the electric chairs We used to do it a lot for basketball when I used to play a lot of basketball back in the day, and that was kind of a great way to isometrically contract the quad muscles. The wall sits, yes, that's another name. So that's the more humane name. I call it electrical chairs because those were torture. Like we do something silly. We put like barbells on top of our thighs sitting against the wall. Those muscles would like feel like you're throwing acid on them. That's how much pain they go through when you held it for a long period of time. But in any case, right, when the knee's bent and you're trying to stand on it, you're activating muscles. So what we do when we stand is we're actually in full extension to prevent that activation of the quads. Because we're in full extension though, the hamstrings actually cannot flex the knee. I'll say that again. When the knee is fully extended in this position where there's absolutely no bend, the hamstrings biomechanically cannot flex the knee. So what we rely on is this popliteus muscle over here that unlocks the knee for us by contracting and internally rotating your tibia or externally rotating your femur. Okay? Now, it will be very hard to visualize, and I try to find a way to kind of help it visualize better, but I wasn't able to. So don't worry about the details. Just know that the popliteus muscle, which sits behind the knee, is very important for unlocking the knee so that the hamstring can do the rest of the work. Now, when people have a problem with their popliteus, they'll have a problem unlocking their knee. And so what they need to do is they need to literally lift their leg while walking and use momentum to unlock their knee. Because when the popliteus is not working, they don't have any other muscle that can do it. Okay, so there is some clinical significance to popliteus as well. Okay, cool. So moving on, we got the flexor hallucis longus, FHL for short. Anytime you hear hallucis, think of the great toe. Hallux is another way of saying the great toe. Oops. This is a muscle that originates over here. I don't know why it doesn't have my labels though. In any case, it originates over here. So it's a large muscle of the posterior leg. It's on the lower thirds of the fibula. So not on the top, more so on the distal aspect of the fibula. And it goes all the way down to the distal phalanx of the great toe, right? So the very last phalanx. Because it goes all the way down there, it flexes the entire toe. So it causes toe flexion. I didn't add a diagram for that, damn it. Okay, let me see if I can find one on the internet, the interweb. Okay, so hope everyone can see this, but this is toe flexion. So that's bringing your toe down. Now, this is a deformity where it looks like they may have destroyed their extensor tendon. But in any case, when you bend your toe forward like that, that's toe flexion, okay, guys? So that's what this muscle does. Now, this muscle is also very important for the gait cycle or the walking cycle, right? What I was talking about before is that the toe is the last piece of that push-off, and hence a lot of force must go through the toe. And a big contributor to that toe-off phase of the walking cycle is this flexor hallucis longus to help push off and push forward. It's that final thrust, so to speak, right? This is when your calf muscles and all the other muscles are fully contracted. This muscle is still doing a little bit of work at that last phase. So it's a really important muscle, and it's also a muscle that contributes to the arch of the foot as well. Okay, cool. Now let's move into the tibialis posterior, which is one of my favorite muscles as well, because it's often implicated in problems such as quote unquote flat feet. The tibialis posterior is a muscle that kind of arises somewhere between the tibia and the fibula, as well as the interosseous border between the two. So it originates from both. Now, it takes that oblique turn medially, and it kind of enters the bottom of the foot by crossing the medial malleolus posteriorly. Okay, so that medial malleolus is that bony prominence of the tibia, the distal tibia over here. And remember, the lateral malleolus, which is what we were talking about earlier, is over here. That's that distal aspect of the fibula. So that tibialis posterior muscle runs all the way down, crosses that medial malleolus posteriorly, so behind it, and attaches to many different tarsal bones. Primarily, it attaches to that navicular bone. And if you remember, I was talking about how that navicular had a tibial tuberosity, right? So if we go back, actually, no, it's gonna be too much work. But in any case, it has a tibial tuberosity where this tendon actually attaches to. Okay. Now, this muscle is a really good plantar flexor of the foot, as well as an inverter of the foot. So it plantar flexors and inverts the foot. Let me show you how that looks. And I was supposed to go through this slide. Okay. So the tibialis posterior will plantar flex the foot, but it will also invert the foot. So inversion looks like this, guys. So if you were to have your feet dangling right now and you pulled it inwardly like that, you'd be activating your tibialis posterior. Okay. And the flexor hallucis longus also plantar flexes the foot, but it also flexes the toes because it goes all the way to that distal phalanx of the great toe, meaning it could flex the toes as well as plantar flex the ankle, right? Because that flexus hallucis longus crosses the ankle and crosses all the joints of the great toe. And a muscle that crosses the joint influences the joint. Okay. Cool. And its nerve supply is from the tibial nerve, which we'll talk about in a bit. Okay. Now, the last muscle I want to talk about is the flexor digitorum longus. So again, the names kind of give us a clue as to what these muscles are doing. For example, flexor hallucis longus, we know that it's a flexor of some sort. It's going to influence the toe because of the name here. And longus meaning it's a longer one. There's a brevis, which is a shorter version of it. Now, if you look at flexor digitorum longus, we know again flexor, so it's going to flex something. Digitorum means it's going to affect multiple digits, and longus, so it's a long version of a muscle, and there's a shorter version of it as well. So based on this name itself, you can already guess that it's going to flex the remaining toes that are not influenced by the flexor hallucis longus. If you look at this tendon path, it's actually going all the way to the distal phalanx of digits 2 to 4. So it can flex all the toes to its entirety. Every single one of these joints are flexed. It's also a pretty potent plantar flexor of the ankle. Again, plantar flexion is this motion, right? Pushing the pedal, so to speak. All right, that was a pretty heavy slide. Carrying on. So this is a very weird looking slide. I bring it up just because I want to give you kind of a taste of what anatomy would actually look like. I refrain from giving you a truly anatomical image just because it would be hard to visualize. But when you kind of cut through a cadaver, you're not going to see all the glorious colors as well as these distinct borders that you see over here. Everything looks almost identical in the human body, right? Especially in a cadaver where the blood is drained out of the body and it's being preserved by formaldehyde, which is a very awful smelling chemical. It's a carcinogen, so never mess around with it. Always handle it with care. But you'll never see these nice, glorious borders. So what we do as anatomists is we'll come up with ways to help orient ourselves by finding out how things should be ordered in the human body, and then coming up with pretty stupid acronyms for it. But it works. And because it's stupid, it actually works. So the example I give here is the acronym we like to use for the medial foot, which is Tom, Dick, and Not Very Hairy. And I think it's in reference to some sort of TV show or like old school comedy or something. I'm not 100% sure. I never really looked into it. It's just, it always stuck to me. And that's because every single word over here, its first letter refers to what we look at in order in the medial foot, right? So starting with the anterior most part, which would be Tom, we have the tibialis posterior tendon. So when we look at the actual foot anatomically, if we're actually holding it, this would be the anterior most tendon that we'd be looking at, okay? If we go a little more posterior, we get into the dick portion, which is flexor digitorum longus, so D over here. That would be the next thing we'd see, okay? And then when we get into and not very, we would see the artery and the vein, the artery, the nerve, and the vein, which corresponds to and not very, as well. Obviously not in these glorious colors over here. The vein you don't see so much because in a cadaver, when a cadaver has been drained, the veins usually collapse because they don't have a lot of elastic integrity to them. Whereas the arteries are a little bit easier to visualize because they're pretty integral, you know, like they have a lot of integrity to their walls. Okay, thank you, Arjena. So Arjena is mentioning that Tom, Dick, and Harry were very common names. So the phrase is normally every Tom, Dick, and Harry, meaning like everyone. Okay, gotcha. You learn something. You learn something new every day. So there's a little bit more history of where this came from. Okay. Now, I also want to kind of bring up the tibial artery, which is this one over here. We know it's a tibial artery because it's the medial side and it's next to the tibia. It's one that I like to palpate a lot. It's one that you can get a pretty good pulse from. So if you guys go into, I don't know if you guys want to try palpating right now, but if you guys reach into your medial foot, which is your medial malleolus, that big prominence that comes out of the side of your ankle medially, and you just go posterior to it. And if you palpate enough, maybe not do it now because you might be sitting and it might be hard to relax that area, but eventually what I want you guys to try as homework is seeing if you could find that pulse over there. And I'm feeling it right now. So I check for this pulse a lot when I'm presented with a client that has foot pain or ankle pain. And it's just my way of clearing if there's any kind of obstruction to blood flow or any loss to blood flow, just to clear that, because that could be a red flag for a more serious pathology. So we tend to check this a lot just to make sure that the foot pain is not arising from the fact that the artery is not doing its job to send blood flow, which could need more serious medical attention, which I would then refer them to a hospital. But it's just something to keep note of, right? Clinically, at least. So it's always important to know the arteries. One major one is the tibial artery. That's one that I often go to palpate. Another one is called the dorsalis pedis, and that's on the top of the foot. We're going to be talking about in our last lecture. But that's kind of why I like to talk about the arteries a bit as well. Okay, so we got Tom, Dick, and not very. And then Harry would be flexor hallucis longus. And you can see mostly it's muscle body over here, and eventually it turns into tendon as you get closer and closer down to the foot. Okay. So again, we use these acronyms a lot to give us an idea of the orientation. Does anyone know which tendon this is? If I were to ask that right now, I haven't really talked about it yet, but this is a pretty special tendon. I'm going to leave that as a question as we carry on. I'll see if anyone knows what it is. All right, so I guess a quick review of the deep posterior leg. So we'll start with the very top. If you guys remember that adductor hiatus, that was that hole in the adductor magnus muscle that allows certain structures to flow through, including veins and nerves. Then we move a little more distally, and you can see the two heads of the gastrocnemius, but it's been cut off to kind of expose the deeper muscles. And as we move further down, you can see the popliteus over here, making that nice little cross from lateral to medial. So the popliteus originates from here, being covered by the gastrocs, and moves medially obliquely to attach to the medial side of that tibia. That's the muscle that unlocks the knee. And if we go more posteriorly, you'll notice that we have the soleus over here, but it's cut to expose more layers. And then we'll go a little more distally. We see the flexor digitorum longus, the flexor hallucis longus, and the tibialis posterior. And you'll see that when they're not really color coordinated, it's a little bit hard to distinguish. So you have to start using orientation. So we know that the flexor digitorum longus, for example, is more medial. The flexor hallucis longus is more lateral. And then the tibialis posterior is more of that middle type orientation. Cool. And we have an answer. So let's go back. And the answer is right. Tibialis anterior. So good on you, Sarah, for getting that. That is definitely the tibialis anterior tendon over there. Awesome stuff. All right, so let's briefly get into the lateral leg. And then what I think we'll do is we'll start lecture 6 next time, right after foot osteology. Okay. So when we're talking about the lateral leg, we're really referring to 2 muscles in particular. Just to get a quick orientation, are we looking at the right or left leg over here right now? Is this the right leg or the left leg? Let's get a quick poll right now. Okay, awesome job, guys. Yeah, we're definitely looking at the right leg. Awesome. Okay, so there are 2 pretty important muscles on the lateral leg, often implicated in injuries. Let's start with the longest. So the Peroneus longus, as you can see, it begins at the head of the fibula laterally, and it runs all the way down, turns into a tendon at the distalmost part of the fibula, and the tendon courses behind the lateral malleolus, lateral to the calcaneus, and then underneath that calcaneus. And then if you see the continuation of the tendon over here, just picture it being below all these bones, all the metatarsals, and it kind of crosses obliquely to attach to the base of the medial cuneiform bone. Right, so that cuneiform bone over here, those are the 3 cuneiforms. So we have the medial, we have the intermediate, and we have the lateral cuneiforms. So just to give you an orientation, guys, the lateral malleolus would be somewhere over here. That Peroneus longus would come in through here, underneath the calcaneus, run obliquely and attach to the base of this bone over here, the medial cuneiform bone. Okay. Yeah, so that's the Peroneus longus. Now, the Peroneus brevis, based on its name, it's a smaller muscle, so it originates mid-shaft of the fibula. And what it does is it crosses the lateral malleolus, and its tendon, which I have in green over here, runs underneath a couple of structures called retinoculum, before it attaches to the base of the fifth metatarsal, which I called earlier the styloid process. So to give you an idea of where the Peroneus Brevis attaches to, I'll show you again. If you look at the diagram over here where my cursor is, there's that styloid process of the fifth metatarsal, and that's where that Peroneus Brevis tendon is attaching to. So right over here in the red. Okay. Now both of these tendons hook, we know they both hook behind the lateral malleolus. Because they hook behind the malleolus, they both function to cause plantar flexion, which is the pressing the foot pedal motion. But we call them accessory plantar flexors because they're not the main ones, they assist in it, right? But we don't look at them as the primary plantar flexors of the human body. But they are there, they plantar flex. Their main role actually is foot eversion. Right? So biomechanically, they're actually perfect for everting the foot, which is the opposite of inversion. So we talked about how tibialis posterior inverts the foot. These muscles, the peroneal muscles, so peroneus longus and brevis, actually evert the foot. So I'll show you how that looks. So eversion would be this motion over here. So trying to flatten your foot or bring the outside even further out away from the body would be eversion. And if you compare inversion to eversion, you can already tell that we have more inversion range of motion than we do eversion. Okay. So these guys are the primary foot everters. And then we have the retinacular tissue. So let's talk a bit about that. Retinaculum itself is a band of thick and deep fascia, right? So you guys remember how we have the deep fascia that wraps around the separate muscle layers and groups muscles together into compartments. Right now we're in the lateral compartment of the leg. We also have the anterior compartment as well as the posterior compartment. Now, apart from those deep fascial coverings, we also have thickening of them at certain points, and this is one of them. And so we call this retinacular tissue. They function primarily to hold tendons down in place along a path of motion. Without these thick bands of tissues, we'd have tendons popping all over the place in our skin, which is really weird to think about, right? But let's say we didn't have these, let's say we didn't have these two bands of retinacular tissue right here. Your Peroneus Brevis tendon would automatically start popping outside laterally every time your muscle would contract because it would have nothing to hold it in place, right? Skin's not too strong. As you all know, you can pull on skin and you can keep pulling because it's pretty elastic. So we have these bands of tissue that kind of hold it in place like a staple would, I guess, to a bulletin board. But in any case, that's how retinacular tissue functions. We also have very important retinacular tissue elsewhere on the foot as well as the hand. Do you guys remember the very important retinacular tissue at the wrist? And if so, what did we call it? It made up the carpal tunnel, if you remember. I'll see if you guys remember that one. What's that important retinacular tissue that we had at the wrist? It made that anterior border of your carpal tunnel, by the way, guys. Do you guys remember? Right around here. I know we're going back to semester 1, but in my defense, it was the last lecture. And no worries at all if you don't remember. I personally wouldn't remember if I was taking this class right now. It's way back, but it's something to think about, right? And Sarah's on top of her game today. Flexor retinaculum. Got it right. So it's the flexor retinaculum. I think it may even be called the transverse retinaculum too, actually. Let me take a look at that, Melanie. I'm pretty sure I've heard of it called the transverse. Let's take a look. Maybe. I'm not 100% sure. So my brief Google search is not helping me out right now, but you may actually be right as well. So yeah, we have retinacular tissue all over the place, and they function as ways to keep tendons in one place without jumping around. They also have a protective role to protect the tendons as well. So that's kind of how retinacular tissue functions. Now, the innervation of these muscles is the superficial peroneal nerve. So we'll talk about it in the next lecture. I'm actually going to go through an entire slide talking about the different nerves we have in our leg. Not sure why my slideshow is not exiting. There we go. So in the next lecture, we're going to be going over all the nerves that kind of originate from the piriformis, so the sciatic nerve and all the divisions. So don't get too confused about the nerves yet. I know I haven't really touched upon it too much, but that's the end of the lecture for today. So I did want to make a quick announcement though. Given how we're all kind of returning back to normal lives and stuff like that, I'm beginning to go back to the clinic, and we're opening another clinic as well. It might be a little bit tougher to do Tuesdays and Thursdays at this time, guys. I know I've changed the schedule once already. So I want to kind of pick your guys' brains. If we were to change the class, I'm thinking a good time might be a Saturday. So I know most of you guys are probably not working on Saturdays, I think. I'm not sure. But what I'm thinking is maybe Saturday. So what I'll do is I'll kind of create a poll like I did last time, get your feedback on that. And if we do Saturday, I think maybe even 9 or 10 a.m. on Saturday. Maybe 9. I don't know. We'll see. But we might have to kind of reduce it to once a week, but I'll try my best to make the lectures a little more focused. I'll see what else I can add in terms of value to the lectures so that you guys can get more out of it as well. So a couple things, I think we might have to go to a once a week schedule just because we're all starting to get back to work and I'm getting back to my clinicals and stuff. So I'm working the entire week. So that might make it a little more difficult. So what I'll do is I'll ask you guys through Facebook to get your feedback, and we'll go from there. The next lecture is going to be the last lecture for semester 2. So that's going to concern the foot and all the intrinsic muscles of the foot. In the meantime, again, I'll set up a poll and we'll get you guys feedback, and we'll kind of go from there. Also, this Thursday, I might have to cancel this Thursday. Really, really sorry about that, guys. It's just we have to get things set up in the clinic, especially the one we have in Mississauga. So we're just trying to get that set up ASAP now that the government is letting us practice at a larger scale. So that's the main reason why I won't be able to do this Thursday. But if I can't do this Thursday, I'll actually probably start this Saturday just to make sure we have the continuity, because I don't want to leave too much of a gap between classes. So I know it's important to have a continuous schedule. So I'll keep you guys all posted, but likely might have to cancel this Thursday. But if I do cancel Thursday, it's because I will add Saturday morning. Okay. So thank you guys so much for tuning in. If you have any questions, I'll be around for the next 5 to 10 minutes. Otherwise, have an awesome week. You guys are getting much better with your anatomy. I'm so proud of you guys. And yeah, we'll communicate through the Facebook group. And if